Hey, okay. So I will start. My name is Andrew Sekeres. I am a policy developer here at the Coverage and Benefits team. I used to work with directly with Lindsay Baywall. I'm on her team and everything. So a little bit background about myself. I have a master's degree in social work from IUPUI. I'm currently um, studying for my licensure test that I'll be taking next month. So hopefully I can pass it. Yeah. So a little bit of background about me. I have been working for the state right now for about a year and a month. And before that, I used to work for CMHC for 4.5 years. And then before that, for 12 years of my life, I lived in Japan as an English teacher. So for me right now, I am deeply passionate about behavioral health and also all of the good work that CMHCs do, and and what you're trying to do and everything, and having that background of CMHCs and also being involved in a little bit of Indiana Council. When I was actually at the CMHC I used to work at during my practicum, I used to join the Indiana Council meetings. So I'm somewhat familiar with your group and what you do and everything. And yeah, nice to meet all of you.
Wonderful. Well, we're so thankful that life has come full circle and that you're in this role as well, and really look forward to working with you. So, Trevor, you want to share a little bit about yourself?
Yeah, for sure. So as she said, my name is Trevor Rhoad. I've been with the state for about a year now. I'm a provider relations specialist, also a representative in the OTP meetings, along with the Indiana Council for OMPP. Um, Kind of one of my teammates put it the other day, we're kind of like a jack of all trades, master of none. So we know a little bit about a lot of things. So um, get to do a lot of things, helping out with providers, questions they send in, provider education events, a whole bunch of things. So as always said, we're always a resource if you have questions or need things sorted out. So we're always happy to be helpful.
Wonderful. Yes. And just to attest to Trevor and Andrew's responsiveness, it doesn't go to a black hole. And if he doesn't know the answer, Trevor always says, I will try to find out for you. And so that's always, I think, a strong leadership skill to have. So I wanted them to have a chance to share some Medicaid updates because, as you all know, there have been a couple Medicaid updates, and Andrew was actually the one that was involved in writing the mobile assessment bulletin. And so, Andrew, you want to kind of give a high level of that, and then we could maybe open it up for questions.
Okay, so as you may already know, as of July 1st, mobile crisis intervention units have been effective in Indiana. I should preface this by saying that right now, only 14 out of the 92 counties in Indiana will have these services due to DMHA. DMHA is doing a slow roll on this. So right now, there is a pilot program that in which they are designating. So in order to become a mobile crisis intervention unit, in order to have that, you must first be designated by DMHA, go through their website, go through their application and apply for it, and wait for DMHA to say, hey, you have been designated as a mobile crisis unit. After that, you will come to Indiana Medicaid, and we are right now in the process of setting up a provider enrollment specialty. So this is similar to if your CMHCs already have your own provider specialty. We're creating one especially for mobile crisis units. I will say there is a little bit of a time of a rollout with this because due to we are working with an outside vendor to create this enrollment specialty, and it is taking some time because projects always do, but it should be completed within the next few months. So our members our members can have these services. And the great thing about the mobile crisis intervention units is this is directly tied to the 988 initiative. that we're trying to provide more access to care in Indiana and everything. And hopefully soon this will be rolled out in all 92 counties. The other thing right now, we did apply for a state plan amendment. Right now, it is currently being in the approval process at CMS. So we're just waiting for CMS approval. It should be hopefully in the next couple of weeks. And then, yeah. So that is mobile crisis units. And I know there have been multiple questions when it comes to the bulletin and things like that. There will be more information in future bulletins about more specifics about the mobile crisis units on who can be on it and things like that. But right now, a lot of the language that is going to be from the bulletin is already in the Indiana code. It is I can't remember the IC right now out of the top of my head. I should know this. But it is already in the Indiana code on who can be on the team. And one of the key things that we do strive for is at least one of the members of the mobile crisis units will be a peer recovery specialist who has been certified by DMHA, who can provide these services, as long as a licensed therapist, and also a licensed social worker, licensed clinical social worker. And then if there is a need, law enforcement and also EMS personnel as well. What we're trying to do, the whole goal with mobile crisis units is trying to step away from calling 911 and having the police arrive on scene, because from what we have seen in the past is whenever you have law enforcement involved, things may happen that we would not like to see. Things may escalate due to the folks that we work with and everything, and we're trying to avoid those complications. We're trying to provide help to where help is needed and everything. So.
And I know that several of you have sent questions, and I have sent those on to the Medicaid team and to the 988 team that is leading this initiative. And so what I would like to pull together is kind of the frequently asked questions with them and some answers, once we get all of those. But did anybody have any questions that you have not sent yet that you wanted to ask and make sure that Trevor, Andrew, and I, yes, Nick, the certified peer recovery specialist question, I did send that on to Trevor as well, regarding that billing and how that's going to be done. I sent that yesterday. So, but does anybody have anything else question-wise that you would like to ask them while we have them regarding this?
I just have one quick question. This is Art Fuller from Hamilton Center. You said, hey, you had mentioned just how if there is a need, like EMS would also be potentially a part of that group. I just wanted to make sure I was understanding that. So that's not a required component. Just wanted to make sure to get clarification on that.
So yes, so EMS is not a required component of this, because we're trying to get away from the model that we have been using for such a long time of calling 911 and using EMS and things like that. Now, even if EMS is needed on the scene, they can come and provide their assistance just like law enforcement. But we're trying to step away from this model, and DMHA has been very strong in this because it's the no wrong door approach. So everybody can have access to these services, regardless of your situation and everything. And if there are situations in which an EMS personnel or a law enforcement personnel may be needed, they may be routed to that situation. But of the two main components on the mobile crisis units will be one for a peer recovery specialist. And yes, I did see the question from Nick, and we are currently doing research on that to get back to you on that. And then also a licensed social worker, a person who is licensed to practice these services in Indiana.
Thank you.
And Barb, I see your hand up.
Yeah, thanks. Two questions. Andrew, could you remind me where the current pilot programs are operating And then the second question is the rest of us who are creating CCBHC mobile response, how will those either be the same or different?
In terms of the four organizations that are involved in the pilot program, actually Zoe knows this information on the top of her head. She's very good at this. I know there are 2 CMHCs right now and 2 community centers. The 2 community centers, the 2 CMHCs, if I got this correctly, is 4C and Porter Stark.
Those will be the 2 CMHCs that will start the billing process as part of that pilot. And then the non-CMHCs, my understanding is they're starting with the CMHCs first, Andrew, to work that out.
Yes.
And then we'll look at what that looks like for the non-CMHCs once the CMHC process is developed according to the bulletin, Barb. Is that helpful? Sort of. Okay.
And then to answer your second question with CCBHCs and how does this apply to mobile crisis units, I will say with CCBHCs right now, this is an ongoing process. We just started looking into applying. So with the CCBHC projects, we are in OMPP, the Office of Medicaid Policy and Planning, is in deep collaboration with the MHA over this. We are involved in various work streams to make sure that we get this right. But I will say this will take time. It will. With the CCBHC launches, you may have heard from DMHA that it will be. We're looking to apply for the 1115 waiver sometime next year, early next year in February. And then also we're looking also potentially at a state plan amendment, and these will take time. And when we do that, we are also going to be looking at how CCBHCs and then also mobile crisis units, how they work together. So this is something that we're currently looking at, but we do not have any information that we can share with you right now.
And Jeff, I see your hand up. I think I know your question about the 988, but do you want to go ahead and ask it?
No,
Okay.
Zoe, I sent that too. I actually have I think what may be helpful too is clarification on who can make up the team. So I've heard and mentioned and a licensed social worker. I believe the code has an and in it, but it also lists 4 different levels. So can it be a peer and an OBHP? What's necessary wouldn't be a licensed person. So I think just some clarification about what the team can be made up of, just so we're clear on what those teams need to look like.
Yeah, I think that would be helpful. And then also your question so that everybody is aware of it. In order to have Medicaid be billed, does the call have to go through the 988 call centers? Because a lot of folks have their own call center process. And so Andrew and Trevor, I sent that to you. But that would be really limiting, especially in a large operation like Eskenazi, who has their own call phone number from a billing standpoint. So I sent that, I want to say last week to you guys, so we can add that to our running list. Unless you have the answer for that, but I'm thinking we're still working on those things, right? Yeah, okay. And then I saw Parkview's hand up.
Hi, Zoe, thank you.
Yeah.
Andrew, I think my question was around the same thing about who can be on the team. I know that the statute says that it has to be supervised by someone who's licensed or in that area, at least to provide that clinical supervision. But the way that we have our mobile team working right now is with OBHP and peers. So really looking at that case management aspect in peers to help them get to the services that they need and then get in to see a licensed clinician. I don't know what other people are doing around the state. We do have a community catalyst grant, which is allowing us to do the mobile team right now. And so we're very interested in getting that on its own sustainability and becoming part of a CMHC that can bill. So any advice or any insight you can give us would be helpful.
Okay, so right now I'm actually looking at the SPA that we submitted for the information on who can be on the mobile crisis unit. I will preface this by saying that this information was supposed to go into the bulletin, but after some discussions with ONPP, we decided to take it out. But we will probably be putting this into a bulletin, but we do not know yet. We are still in the phases of that because we are understanding that there is some confusion around this and everything, especially with how we're trying to do the enrollment. So I can tell you, from the SPA, this is what is right now being currently being looked at DMHA at CMS is first individuals certified in peer recovery services. So those individuals who have been certified by DMHA, who is a peer recovery specialist, can be on the team, and at least one of the following: behavioral health professional license under IC 2523.6, including marriage and family therapists, social workers, mental health counselors, addiction counselors, and clinical addiction counselors. So your LCACs, your LACs, your LMHCs, your LSWs, your LCSWs, all those fancy acronyms that we love so much, and other behavioral health professionals as defined by 440 Indiana Administrative Code 11112, working under a community mental health center. So this is an OBHP that must be working under a community mental health center. If you're in a private practice and you have OBHPs working for you, unfortunately, they cannot provide these services. And then also emergency medical services personnel license under IC 1631, which is your EMS services, and law enforcement based core responder behavioral health teams. They may be involved as well if needed. But once again, we are trying to step away from EMS and law enforcement if needed, but at least to have a peer recovery specialist. This is the main person, and then also having at least a behavioral health, a professional license, or an OBHP. Then also mobile crisis units must be provided under the supervision of a behavioral health professional license under IC 252326. These are what we call our mid-level practitioners, your LCSWs, your LCACs, all your four-letter people, licensed physicians, and a licensed APRN or clinical nurse specialist. These are the individuals who can provide supervision to the mobile crisis teams. And also, it should be noted that that supervision may be performed remotely as well in the worlds, and right now with telehealth and things like that. As of right now, we are allowing to do with telehealth. But the other thing to keep in mind is with the telehealth codes, right now they are active until the end of the year, and then we are going to reevaluate again the telehealth codes. So that's still an ongoing discussion.
Okay, great question. Well, I know that the 988 team is going to be a significant part of our July conference. And so hopefully we will have some more answers for all of you regarding this process during that session. So moving on, I wanted to also, there's a couple other things to highlight that Trevor has also been helping us on. And that, Tim, is your famous question about the rates and the rate situation with the increases, because I see several of my CFO friends and members on this line. And so Trevor does have that rate breakdown that you did, Tim, and we are following up with the revenue and billing folks to get an answer confirmation on that, but that has not yet been received, right, Trevor? We're still working on that.
Yeah, not as of this morning. I know reimbursement was still working on they were still reviewing, but they're going to get back to me. So once I hear back from them, I'll forward it to you and we can spread that out.
So that's also some exciting news that Medicaid has been working on, is that standard rate increase to start this upcoming fiscal. And so the CFO committee and Tim's leadership put together well, is this what this exactly will look like for us? And so we're getting confirmation on that. And we will also hopefully have that for our July discussion, because Tim and Jeff Reed will be leading us in a financial discussion where those gaps are and what we need to look at from a policy and advocacy standpoint. So I really appreciate Tim's leadership, and also kind encouragement to keep checking on Medicaid to see where we're at with all of that. So Trevor, anything else outside of mobile and rates that you want to highlight that Medicaid is working on?
Off the top of my head, I'm not thinking of anything. I know you sent a couple of questions, which I'm still waiting to hear back on a couple of those. Things have been kind of hectic around here, but yeah, I know, as Andrew highlighted, still working on the mobile crisis things. And then with the rates, once I hear back on that, I'll be able to get back with you. But outside of that, still waiting on a few questions that I know you had sent in. But yeah, so I don't have any specific updates outside of that.
I can also add, I did look at the questions that you sent over, Zoe, for the, this is in regards to the 1115 waiver for the incarcerated issue. We are currently looking into this. So ONPP is working along with DMHA and also the Department of Corrections on how to do this. We are currently looking into it. This has been going on for at least a few months right now, but we are still trying to figure this out because one of the issues that we always run into is like our bandwidth for especially for data and everything. But there is actually good news with that. With the Department of Corrections, they're actually really good with data, so we'll be actually using them to help with the data for this. So this is something that we are looking towards right now, but that's the only thing that I can say right now. It is in the works, but we cannot say nothing definite. There are no major plans, but it is something currently being discussed.
Yeah, that's wonderful. Since I think not last session, but the session before that, we did put that in policy that Indiana will submit that waiver. And I know California, I keep thinking, can we just change California to Indiana and get that submitted? Like, let's not make it that much harder. So hopefully we can continue to advocate for that, especially the significance of that, Andrew and Trevor, with House Bill 1006. And the changes that have been made with the hold process and what that is now putting on providers directly. Having that direct connection from the incarcerated and the Medicaid is very significant for us as we're working through what House Bill 1006. So that's I think making it a little bit more of a priority for us to continue to advocate for. So I appreciate that update. So I know we're 2 minutes before wrap up. Time flies when you're having fun with Medicaid. And so anything else question wise that are on all of your hearts and minds that you'd like to ask Trevor or Andrew? Okay, well, I will keep you all posted on the answers and the discussion. I did want to highlight that we do have several committee meetings coming up. I do see some new faces on the phone. And so if you're on the webinar, if you're not plugged in to the council or to one of our committees, please reach out to Denise so we can get you plugged in. Today at 10, our Child and Adolescent Committee is meeting. They have been instrumental in forming our July conference, so really grateful for that work. July 14th at 9 is our Data Analytics Committee. This committee is shepherding our state data warehouse that the council is looking to do with all of you and has been wonderful at providing the data in the meantime for things like Medicaid and DMHA. Our Medical Directors Committee is July 14th. For those of you on public policy or involved in policy, July 18th and July 20th, there are a number of federal legislator meetings taking place. And if you are in that district, Denise has sent those invitations out. So I wanted to highlight we're doing some work on a federal level as well. July 20th is our Racial Equity and Leadership Committee that I'll be sending some information out to everyone on about getting involved in that committee, especially for our BIPOC workforce. And then our committee chair, so all my committee chairs on the line, July 19th, we will be connecting so that we can be ready for our in-person committee meetings taking place on July 26th, July 27th. We are starting the morning with yoga and mindfulness. Please register for that so we know that we have enough space so we can get in that headspace, because July 27th, I know you guys like breaks. I built a few in, but we have a very full schedule for youth services on July 27th in Muncie. We will also be celebrating Hank's retirement in the morning, as well as July 28th, having our member-only meeting discussion around County Commissioner and the CCBHC RFI. We have about 123 folks registered. So if you have not gone on and registered, please go ahead and do so. Our newsletter is in progress, and I'll be sending out an email update this week with several important things, especially around the CCBHC RFI that just rolled out. So stay tuned for that. And our winner of our Cup of Joe, because he is so festive, let me see, where are you? There he is, Art Fuller. With your lei, we have to pick you. Look at that. I mean, that's a summer festive. So
hey, what a wonderful day. We have like a Hawaiian day here.
Yeah, that's fantastic. If you show up on a lei on Cup of Joe, you're going to win a Starbucks gift card. That just stands right out. So
thank you very much.
I appreciate you bringing the festive. So let's raise our cups because it's just 2 minutes past 9. And cheers to all of you. Thank you, Medicaid, for being on. We look forward to continuing to partner with you and look forward to seeing all of you in person here in a few weeks. Have a wonderful day, everyone. Take care.
All right.